Thursday, this coming Thursday. Yeah.
First time we were meeting.
Yeah, we've been doing everything virtual. Some of the resident conferences we've been doing in person because they're smaller. But, we're transitioning back to full conferences this month. I was a senior in college when I was out with a friend and I went down to pay a check. And she's like, "Do you know you're bald?" And I'm like, I didn't know I had. I was like 20 years old.
Yeah.
Okay, I'm leaving you.
You ready to go?
You're ready.
Yeah, so welcome back everyone to in-person grand rounds or visiting professor. Really exciting to be in this place after a very long time. So without further ado, I'm going to let Jim Parker, division head of foot and ankle, introduce our speaker last night, who joined us last night for dinner and also case presentation. So Joe.
Thanks, Ray. So it's really a pleasure to welcome Dr. O'Malley today. You know, he's truly a pioneer and leader in foot and ankle surgery, especially in the treatment of elite athletes, as you'll hear today. But I think for me personally, you know, he's served as a teacher and mentor for many of us, including myself, Dr. Cooper, Dr. Carmel. He was always willing to share his advice and guidance for how to treat these patients, including some of our UVA athletes. He's an associate professor at Weill Medical College at Cornell University. He's been on faculty at the Hospital for Special Surgery since 1993. He's got over 100 peer-reviewed articles as well as 24 book chapters. I think that's a new updated CV. He graduated from Case Western School of Medicine and his residency at Tufts University and finished his fellowship at HSS and St. Luke's Roosevelt Hospital in New York. He's currently the team physician for the Brooklyn Nets, USA Basketball, Iona College, as well as the New York Giants. But truthfully, he helps all NFL teams, all NBA teams, anybody in sports who has a foot and ankle injury has probably seen Dr. O'Malley at some point. But we're truly honored to have him as our visiting professor today for our grand rounds. Please join me in welcoming Dr. O'Malley as he presents on his experience caring for professional athletes, especially with stress fractures, Achilles injuries, and high ankle speed.
Thanks, everyone, for this warm welcome, and thanks for obviously that great dinner last night. I like when someone shows up and pays the bill at the end. That's the chairman's job.
Right.
And thanks, Joe, for inviting me. These are my affiliations. Let me go. These are my disclosures. The only thing we'll talk a little bit about weight-bearing CT scan and diagnosis of syndesmosis injuries. So I think it's important when people introduce you for grand rounds to see where you came from. So I'm from Cleveland. Everyone thinks I'm from New York because I mumble and I talk fast, but it's actually because I'm one of 7 kids and we had one phone, so you wouldn't know how to mumble on the corner of the room. I ended up going to Hamilton College, playing football there because Ohio State wasn't looking for 5'11" slow wide receivers. I ended up going then to Case, then into Tufts, and then did my fellowship in New York. And I actually did the fellowship in New York because I was 33 and single, and I had to find a place to do a fellowship. And I got really lucky because Bill Hamilton was was my mentor there, and he was at that point he was a ballet doctor, self-taught ballet doctor, but also took care of all the professional athletes. Sports medicine at that point of the foot and ankle was almost non-existent except for him. And so I was lucky to spend a year with him. And afterwards, we maintained this relationship. So most of what I learned about sports, foot and ankle at the beginning was due to Bill Hamilton, and I'm grateful for that affiliation. The second sort of fortunate thing is they offered me a job at special surgery. At that point, I was the 27th orthopedic surgeon hired. There are now 140 orthopedic surgeons. And as I walk in here today and see the residents in one area and all you guys seeing patients together, it just makes me long for those days. We are so spread out now over so many different buildings. When I started in practice, I would go for a walk. I'd have a bad case and I would go find the hip guy or the sports guy, and I was just asking questions. And it's almost impossible to do that now because we're probably over 7 or 8 buildings, and there's places on the west side, there's Midtown. So there's probably a sweet spot in terms of the size of your department, and I think it's probably 30. where you can still have some collegiality. I have guys and staff who I've never met. They've been there for 3 years. I've never actually met. Now COVID's a little bit, but that's mostly because we're so spread out. And then it's because of an HSS, they take care of a lot of teams. And so for the first 10 years of my life, the patients would come to see me from the sports guys, and I'd tell them what they would do. And then they would go back to the sports guys and have the operation. They'd go some other city and have the operation. And all of a sudden we had one patient who had a Liz Frank injury, NBA player, pretty well-known NBA player, collapsed midfoot, and I fused his midfoot. He actually went back and played. And that's sort of started it. So that the first area of luck is picking a fellowship with a sports guy. And then the second is being at a hospital where people would send you patients, and I would get a lot of kind of at-bats. I didn't really know what to do, but I would give my opinion. I could see what they ended up doing. I would learn a lot doing that. And then a friend of mine became the Knicks doctor. And he said, look, I'm going to be the next doctor, but I don't know anything about foot and ankle. Will you be my assistant? And that's what started my journey on this. So this is 2003. I was the Knicks doctor for 5 years. The Nets had a couple problems afterwards, and I did a couple operations. And then the Nets said, will you be our doctor too? So for 3 years, I had credentials for both teams. I would never go to either the games when they played each other, but I would sneak back and forth between New Jersey and Madison Square Garden. And being a team physician, one of the things about being an NBA team physician is that you take care of your own team, but as importantly, you take care of the visiting team. So at the end of the game, you go and visit the other team's locker room. So you meet their performance staff, and you meet the other players, and you meet the coaches. And that's how the NBA is a very tight little community, and that's how you get to learn everyone, and everyone knows you. So everyone, when the residents come out, like, I want your job. I'm like, I keep telling them, it wasn't a plan. It was never a plan to be a sports doctor. I just was going to do a foot and ankle job. And then I did a lot of reconstruction. Like when I started, I did every crazy crooked foot with IM rods before they had good rods for doing extended talar calcaneal fusions. But they come to me because a couple things. One is foot and ankle. If you look at injuries in sports, there's the preponderance is foot and ankle injuries. If you look at the NBA from last week, the injury report, 10 or 12 are foot and ankle. And most of them, if I haven't seen the player, I've seen their images. They just, hey, can you look at this? And so since I got here last night, how crazy it's gotten. I have 3 consults since last night. Now, I may never see any of them, but because of, internet, they just send you the images. Can you look at this? Which is a blessing, and it's nice, but it's also a curse in terms of trying to have a free thought and a couple moments to yourself. So as a team physician, you cover your team, you meet the performance staff. The other thing is, so there's 64 NBA team physicians and part of the NBA Physicians Association. There are, up until last year, there's 63 sports medicine guys and 1 foot and ankle guy. So, it's a little bit of foresight for Answorth saying, I need help doing foot and ankle. And that's how I got involved in it. So the other reason is the patients come to me with the agent. So if the way it works is someone gets hurt, the agent controls everything. And there's 5 agents who control most of these players. So these are guys that I've seen for different things, but these 5 guys are, and this is the contracts they have, they control the NBA. So 4 of the 5 send me their patients. The other one sends me the x-rays, but he usually doesn't send me the patients. So, but that's okay, but if you look at that, the NBA contracts are all guaranteed. There's a strong players association, powerful agents. So when they're negotiating these agreements, the agents are involved in their back channel, and they have long careers compared to the NFL. The NFL, the signing bonus is the big thing that's guaranteed. Now with Rodgers and Sean Watson, they got some guaranteed money, but most of the time you have a contract, you get your signing bonus. Versus the NBA, all these guys are guaranteed. So the 20th highest paid player in the NBA is making $33 million. Just to give you a perspective of oh yeah, and he hasn't played. Oh no, there are 5 players out there who have hardly played this year of the top 20. So compared to the way the NFL's works, if you look at when Mahomes got his $450 million contract, it was guaranteed signing was $63 million. I mean, that's still an insane amount of money, but it's not the same. If you get hurt in the NFL, it is not a good thing. If you get hurt in the NBA, you're protected. So we had a couple of years ago, we had 4 guys get hurt at one time. They had a fifth metatarsal, high ankle injury, Odell fractures and all this. It's all in the paper. So the HIPAA rules are out because everything's on the internet. So the next Monday morning, I fixed 3 NFL players. It would have taken me 2 weeks to fix 3 NBA players, just in terms of going back and forth between the agents and the teams and getting second opinions. The NFL guys will just show up, I broke my ankle, I need it fixed. And the agents are not as much involved. They're involved, but you don't talk to the agents first. NBA, you talk to the agents first. So the good part about this whole thing is this whole NBA experience that I get in meeting with these players, and they're in my office, and I'm old, so I'm 60 years old. So to have a whole group of friends who are in their 30 going through these crazy life experiences with this unbelievable amount of money, and just seeing how they navigate their worlds is just really interesting. And you learn about your preconceptions. Like, everybody thinks Odell Beckham was like a bad guy. He is the best player you could want. He'd be the nicest guy to your office staff. He'd be the most compliant guy in the world. I mean, he had a fracture dislocation of his ankle with high ankle sprain with 12 screws, medial deltoid repair, the whole thing. At 3 months, he sends me a video. He's running and catching football. I mean, it's so taking care of them is really unique because it's a whole different genetic background than me. Like, I played Division III football. I've got nothing to do with this. Like, the amount of athletic ability these guys have is just crazy. So the other part is you get this travel. You get to roll in with the Nets on the team plane, and you get travel experiences you never would have had, which is really an exciting part of your life. We've had some experiences. I got to take my son to China on an 80-person jet, with a bar area that looked like a Las Vegas lounge. And I'm part of a team. I mean, we're on the team bus. Like, the owner of the Nets he doesn't come to the locker room much. The owner and the management and the team is different. And as the team doctor, you are part of the team. You're privy to everything. And like, if someone from the front office tries to get on the team bus, they couldn't get on the bus. They have to wait for the other bus. And so you're also part of some international crazy things. We're in China, and they're having the tweet. They're shutting down the NBA. There's this international diplomatic crisis because they've tweeted out support of the refugees in China, and the Chinese did not like it. So we're there for a week, and we are not welcome. It is very tense the whole time. They do not want us to be there. They're tearing down the posters. We get there, there's posters all over Shanghai, and by the next day, they're all down. I do get good seats. Everyone thinks I have great seats for the game. Now, from COVID, we've moved off. But for many years, you can see me on SportsCenter. You see this little tuft of gray hair in the second row, and there's Joe. And Jared Allen would sit in front of me, so I couldn't see anything. Basically, at halftime, I would take Motrin because my neck would be so stiff, and often the water tank, the water thing would be next to me, so they'll block my vision to the left. So I'm watching most of the game on the Jumbotron. Access is pretty good. So they give my family access so you can be a cool dad. So, like, my kids have access to all this stuff, which is, if you have children who like basketball, it's good. If you have children who don't like basketball, it's just time away from your family. So I'm lucky in that the sport that I like playing, which is I like basketball, and my children play basketball and they like basketball. So because of that, that's good. And also taking care of this team, it's a practice builder. I mean, your people release information after you have an operation that people see. And it's hard to know how much people read, but people know. And this is just from the HSS website that they've just published this after my name. And social media is big. I don't really know much about social media, but I'll do something, and these guys, someone will tweet something, and it'll come back to my phone. So one of my favorite one ever was, can I do this one? If I can get this, can I get the volume?
I have the volume off on the computer up there. I can turn it on.
Oh, well, the best part about it is he's going to get his ankle right, and he's going to have an operation by Tom O'Malley. This is from the Aristocrats. So he was close. That's AB. That's Antonio Brown. So after he has his whole shirt off, he's in the office, and then he tweets out something, and he comes in the office. see me. I'm going to the Nets game. He is in a different outfit. And he's in the front row of the Nets game before I get there. And I'm driving right there. And I park right there. Somehow he's like Superman. He got to the game before me and has already changed in a completely different outfit. So the good is interesting patients, challenging operations, trying to get your guy to go back and golf versus trying to get your guy to participate and play at the elite level, but fast twitch 1% is really an interesting thing to try and accomplish. It's nice to be part of a team, get access, it's a practice builder. The bad part, it's a bad time suck in your life. It is you, if you're going to be a team physician, you have to be able to, for an MBA team, you have to say, okay, I am giving a lot up. I'm giving up my weekends and nights, and I have to be available to people. I have to answer these calls, and it's a, it's a bigger time in your family. So each of these lanyards comes with a big price. So for example, we're doing, as a team physician, most team physicians get paid about $100,000. That's the going rate for a team physician and for professional sports. We have 41 home games. I usually go to 35. It's about 5 hours if I go from my office. If I go from Connecticut, it's 8 hours. We have preseason travel. So preseason is okay because there's usually a road trip. You can kind of make it feel like a guy's road trip. But it's a week out of your practice. Draft preparation, the draft night is 8 hours. You're there going through this stuff. In-season management. Someone gets traded, you have to review their records. It's hundreds and hundreds of hours. My accountant estimated up to it's about $20 an hour for me to be part of the Nets. So we know that time, not money, is the most precious commodity. So you're really giving up a lot. You have to say, this is really what I want to do, and I love this. And there's a good study that showed working adults report greater happiness after spending money on a time-saving purchase than material purchase. Right, so you're basically happier for someone to cut your lawn than you to buy like a riding tractor. So I'll tell you a story. So the playoffs are coming up. So this is my next 2 months. I don't know what I can do in terms of scheduling because we travel for the playoffs. So the playoffs start April 16th, and if the Nets pull it together, it ends June 17th. So for 2 months, I would be traveling with the team on and off. And when if we go to Miami and have a game, I come back. We don't stay around for 3 days. We come back and we have to see patients because you have your practice, you know, your regular things. So when I'm going away, I said, okay, the first week of the playoffs, don't do more than 2 or 3 operations in the morning on a Tuesday morning in case I have to get to either Miami or Milwaukee or where I'm going. So you're kind of at hostage for a couple months. So a couple of years ago, I had my personal record. I had 8 screws on 7 players on the court at the same time. We were playing the Knicks. And after that, I was done. So here's my story, my best time versus remuneration money. So it's a game 5, 18 million US people are watching, and a third of Canada is watching this finals. And I'm not watching. My son calls me and says, can you get me to Rayo's in New York? And I'm like, Rayo's? No, I can't get you into Rayo's. And honestly, that afternoon, a patient of mine comes in and says, I want you to use my table at Rayo's. I'm like, this is crazy. Like my son just asked me this morning, he goes, all right, so we're going to Rayo's. And so we pick a night, and Rayo's is a small restaurant in New York. You can't get a reservation. It's like a membership, these guys, and it's all like the titans of industry. You have a membership at this restaurant. So I have this restaurant, we're going, it's a Monday night, it's a big night, big Monday night out. My son and his girlfriend, my wife and I are going, we're coming in from Connecticut. We got the Honda Pilot, we got it parked in the garage. We're gonna stay in a hotel. Everything's okay. Talk about the end. I'm sitting right there. There's 15 tables in the whole place, and you don't pay for anything. There's no cash exchange hands. I don't know how it works, but it goes to whoever is paid for. My guy was.
We got a phone call from
Whatever you
John.
want. There's no menu. Guy comes and tells you, what do you want? What do you want to drink? You go through this whole thing. So I'm about.
Well, I
I
don't really understand why they put like Christina in the second room, and they put.
It was getting so
Well,
complicated.
I don't really understand why they would do that. He's got 2 cases in one room, and I've got 6.
So I
Why would
looked
they
at my
put
wife
one
and
in
said,
this room?
she goes, what can you do? Like, they're not even here. I said, I'm just going outside. So I spent the rest of the night outside the hotel, coming back in. And I said, okay, it's fine. We can still go to the hotel. We're still gonna have our night out. And then the rest of the night after that, the phone went off. I was in the bathroom with the fan on, sitting on the toilet, talking to people till about 2:30 in the morning. And then the next day, I have to figure out how to get a 7-foot tall guy into my building. He does not want to be seen. So you go off the FDR drive and behind the dumpster, you can go in there through MRI. And then I have like these people outside my office with their nicks and net signs and all this crazy stuff. They think that actually he's going to have surgery in my office. And so for doing this, open Achilles tendon repair with a very long leg, same medial. And then now we're done. And now the player is a free agent. So now I spend the next month managing his life from post-op care. And look, if you do an Achilles on someone who's been witnessed by 35 million people, you do not want a complication. So every other day I'm watching his wound. I'm visiting him at the hotel. Then he finally signs with us, which I don't know he's going to sign. And then they go to LA. So the team says, you have to get, when someone signs, you have to get a physical within 72 hours. So, okay, we're going to LA, round trip in one day. And then 8 weeks later, I'm going back to LA. So the estimated time for this was about 100 hours. When you do athletes, it's workman's comp in the state they're in, the workman's comp state of California, $934.09. So, you know, you better really appreciate the press release, because otherwise it's your time is like there's nothing to do. Until just when you're complaining, then you realize it's sort of a privilege to take care of these people. And they're again, their genetics is different. So this is 8 weeks post-op. Which is pretty good for 8 weeks post-op, really. You know, double heel rise, this calf looks pretty good. And you're thinking like, all right, this could make me look really good despite whatever I do, because these people just have this ability to heal that I don't understand. So the surgical fees versus stress involved. So when you have a doctor-patient relationship, you talk to your patient and you have this look in their eye and you have this, but when you're with these players, there's all these other things going on in the background. I have operated on 3 players I know just because they don't want to get traded. Clearly they're going to get traded. They had anterior impingement, they had loose pieces in their ankle. They're like, all right, I need to have this fixed now. Guaranteed contract, there's nothing you can say. They have pathology, it's there. So we've operated on people for that. So there's so many other things that are going on and that you don't understand that are flying around the background of these relationships about whether next, like, you know, about their next contract. Do it now because next year they have to be good because that's their contract year. And it's $1 million athletes. Again, this $1 million fees, this is a big facade. This really doesn't care, but the money is just crazy. So I have 4 players with max come to my office. The guys, one guy started signing the jersey. So now it's like a game to sign the jersey, and we put the jerseys up, we rotate them. But we have 4 guys who are making their contracts are worth over $800 million. Those 4 surgeries, we got paid $5,100. So it's not $80 million, it's $800 million. And so this, because it's all workman's comp, it's workman's comp in the state. So if you think you have trouble getting workman's comp in the state of New Jersey, of Virginia, operate on someone in Minnesota and try and get paid from the state of Minnesota for workman's comp. I mean, it's almost impossible. I mean, it takes a year or a year and a half before you get whatever that workman's comp fee. So you're basically doing free care. And then there's the liability. So most states, 1.1 to 3 million. HSS is a little bit better for, as a surgeon to cover you. The average MBA salary is $8.25 million. So you're basically going uninsured for something going wrong. I have a player now who had a complication from a block, who's suing us, who's making $5 million a year. I'm named in the suit. I'm nowhere near my little operation, nowhere near the block, but the block out, so we're all being named. We have Jimmy Andrews was named. This is a pain. They did a long-acting block. He got sued for $800. It's still pending out there. So it's a tremendous amount of liability with these players. And so for my advice, if you're thinking of doing it, if you think you want to be a team physician, the first thing you do is set some limits of at the outset, which I never did, because you show up and you're like, all right, this guy's coming to me. It's pretty great. I'm excited this will come to me. And then it builds and builds. And then you realize 15 years into it, your life is just overwhelmed by these people calling you, and there's no boundaries. Those people are calling you all the time. So you just sort of, for team coverage, find a team and have a discussion with the team. How many days you want me to be there? Do I have to be at every game? And just have a, because you're sort of grateful when you get the team, but then you got to say, hey, I have a life. This is, this is not a dress rehearsal. This is one of Bill Hamilton's best lines, because life is not a dress rehearsal. So you have to know what you want to do. I would get 2 phones. I mean, you get one for the players and the agents, other for personal. And the one thing that COVID has taught us is that telemedicine is reimbursable. So all these consults, you know how everyone drops things on your desk. What would you do? What would you do? What would you do? I would get involved with one of these best doctors or best in class MD sites and just say, okay, if you want this consult, just log your stuff on here. There's a charge, and also for liability, because if you give an opinion, an off the cuff opinion on your desk and something goes wrong, you're liable. So with the COVID, the advantage of the only good thing I think about COVID was that it makes us get reimbursed for our telemedicine. For all the opinions we give for free, it allows us to be reimbursed. So for me, for the pro athletes, what do they come? They come for stress fractures, high ankle sprains, or Achilles. So a lot of times what I do is with in the conference like this, they'll say, what's JOMO? And it's the Journal of Martin O'Malley. It's when I'm completely convinced of something, but I have nothing really to back it up, and the pages are empty. But it's really this, it's a school of my experience in 25 years. So they'll say, what is the JOMO on that? So stress fracture of foot and ankle, the first thing there is blame. The first time someone gets stress fracture, everyone's looking around to blame it. And these guys, when they're on the court, they have trackers on. I mean, they're on practice, everything is tracked. They know their load management. And you have to thank Popovich, the coach for the Spurs, to bring up load management. There's so much pushback about him resting his players. But it's true, the load is important for these guys. And, so first time they get a stress fracture, everyone wants to look at their shoes. Well, there's no way you're changing some guy's shoes. Everyone's got a sneaker contract. Everyone gets paid something to wear some shoes, whether you get free shoes, but some of these sneaker contracts are crazy. Like Kevin Durant gets $25 million a year from Nike. He's not wearing his shoes, right? So common symptoms for the stress fractures, the power athlete get more foot fractures. So I see almost all foot and ankle fractures. And the high risk ones, these are the 4 that are big: anterior tibia, medial middle, navicular proximal fifth. So the anterior tibia much less common than posterior. It's one line versus multiple. It's the dreaded black line. Constant tension from posterior forces. The dancers get these a lot. See a lot of runners with it. And it's a fatal blow to the career of an athlete. If you sit on this for a long time, it takes forever to go away. So it came out, the standard treatment is a discussion, do you do an IM rod or can you plate it? And this goes back to Keith Barner back in 2005, this is 17 years ago, that he did an IM rod for these players, had these patients, and it worked. Study out of Scandinavia used a lateral plate that seemed to work. So, and then David Helfand reported something about doing an anterior plate. Now, the problem with the anterior plate is it's very prone. You put a big plate on someone's anterior tibia, you feel it. And so 5 of the 38 took up hardware. If you have a stress fracture, you're putting the hardware in. It's mechanics. It's either overuse or biomechanics or some combination. You never want to take the hardware out. You say it's in there until you're done playing. So here's a 29-year-old principal dancer. She's had 7 or 8 months of anterior tibia pain. It's hard to think you're going to do an IM rod on that. She's got one line. So we do a little lateral plate. She goes back. She does well. She has a movie. She comes in and films. I'm in the movie. I don't even know I'm in the movie. I'm just thinking, do I have stuff in my teeth? But it opens the Tribeca Film Festival, and she's in the office. Then the classic is the bigger player with multiple lines. You get an IM rod. And for the anterior tibia localized line, this lateral plate is a pretty easy operation. You can compress it. You can probably add some BMAC to it. But multiple lines you want to rod. So I think I have that down pretty well until this kid comes rolling in about 6 months ago. He's a 19-year-old player, 6'10", 260, with one big line on both sides. You can see the stress fractures on this clinically. I call my friends from the trauma, walk over, I say, okay, I think we should rod this. Even though I'm a big plate guy for one single line, I think we should rod this. And they're going like, I don't think we ever rod that long. 2, I don't want to ream both of this kid's tibias because there's some downside from that. They said, you should plate it. Like, all right, so we played it both at once. He walks in, you put the rod, the plate right down there, heals very nicely. 3 months later, he lands from the jump, or 3 or 4 months later, lands from a jump and fractures the left side. So then he gets his rod. So I don't have that one down. So I mean, I think it's if you look at these big athletes, you got to push towards the rod and got pushed back there. And they did find a custom rod to put in. So
So for a contact sport athlete, would you rod it?
yeah, I think mostly rod. I have two, 3 have college basketball players there, right? It mostly goes into how worried I am about their knee. Like there's some data about, getting anterior knee bursitis. Some guys have an ACL, they're a little bit worried about like throwing the rod down through their fixation with tibia. So in most of the contact sports, most of the bigger athletes, I think you should rod it. So the medium wheels, very common in the jumping athletes. This is one that's sneaky. The guys come in, they have a sore ankle, and they can roll in the office with this. Just walk in the office and they see this on CAT scan. This is one that one of guys will be soon here next year. Elite basketball player. He just rolled in last week with that real medium wheel stress fracture. The big issue is a high rate of union, non-union with screws alone. You don't just want to throw a couple screws across it. You want to over-treat this fracture. This is Grant Hill, who had 5 operations to finally, I just get it fixed. I just saw him at USA Basketball, and it's not a good angle. Must address the bony impingement. That's the real key to this. So this is the one that you can really see the reason to get it. Most of these guys have a big spur coming off the anterior medial neck of the talus. And they jump and they land and they jump higher than all of us and they land more than us. And it's repetitive and they just get a little propagated stress fracture up the medialis. The line is almost always the same location. So here's a kid who went to, this is what a usual one, this is from, they're usually always 20 years old. We're just published this, so it's being published, 8 cases in the NBA. The x-rays all look the same and the CAT scans look the same. So overtreated. Here's a kid who came in, who went back to France. He got 2 screws parallel, didn't take care of his impingement. This is at 9 months, still has pain, never really healed. So we had to go back and plate it and do the decompression anteriorly. So the rule with that is overtreated. You can't just throw a couple screws across it. I'd probably have 5 or 6 that fail in just a couple screws, and then and plate these. Watch for the posterior tibial tendon when you plate these. You've got a lot of things going on the posterior tibial tendon from these plates and screws. These are funny. These there's an AO plate and there's a right medical. It really has to do with anatomy. If this is on this one, I bailed out and do this because I just couldn't get it to fit very well. So those plates, the medium list is pretty variable. So these hook plates sometimes don't work very well. This is a guy who had, he's in the NBA, came back after 2 years. He had 2 operations that didn't heal. So he's been out for 2 years with his medium with stress fracture. And finally we got it to heal with this hook plate.
And do you take that hardware out because of how prominent it can be?
No, just tell me it's going to be, this is part of you. Yeah.
How often do you think a varus hindfoot contributes to that too?
Well, it's interesting. This is the only group of varus hindfoot. And if you look at the images in general, it's 90% black athletes. It's rare to see a high arch in a black athlete. It's a flat foot. Mm-hmm. So and some of these guys are crazy. A lot of them it's an international league, so we get guys from Europe, tall guys, 7 foot tall, high arches, a little cavus foot. That's a risk factor. Mm-hmm. But most of the players who have this in our series, the NBA, we looked at the foot position. There was nobody with a high calcaneal pitch. Mm-hmm. So navicular stress fracture is what everyone hates. If a navicular stress fracture comes in your office and you want to go somewhere else, you should just be thankful. This is the one that causes more loss of sleep than anyone else. They have a poor outcome even with optimal, conservative, and operative treatment. It's because of the blood supply. And this fracture, again, with the medium list, the fracture is always in the same line. I mean, this is Jeremy Lin, who's 6'3". Right? So this is obviously an outlier. You're 7'6" and weigh 350 pounds, and you have a high arch. That you're a risk factor. So the data on this, because we have to thank Joe Torg, who's one of the pioneers of sports medicine, for bringing our attention to this. But after that, we just have to ignore him. I'm sorry, because his first study was bringing our attention to it, but it came in 1982. 21 patients, 4 institutions. 14 of the patients they diagnosed by bone scan. So we didn't even know what they had. Only plain imaging to follow up. 4 of 21 results were disabled. All the ORF had good results. So if you look at this, you can only base your treatment on what the CAT scan shows. So there's the classification 0.5 is just edema. These are the hard ones. The kids come in with just edema and a Vicar, and you have to know when I'm going to put a screw across it or the point. Then you have the 0.1, just the top here. 2, these are the worst ones. They're the best when you operate them because you actually squeeze something together, but they're the highest rate of refraction. So when you're putting the screw across this one, are you really compressing anything? Really, you're not really compressing anything. But the third one, the type 3, you feel like you're compressing one, even though they do the worst. So the stress is, what do you do? Non-weight bearing of boot or cast versus internal fixation. This is Saxena. It was a great study. 19 patients and 15 to 16 returned to competitive athletes to full competition. And most of the time you fix them. Fowler and Torb came out with this big review saying, look at you, and he's gone on, at the sports meeting saying that this is malpractice, you're operating this place. 96% of patients non-weight bearing wanted to heal at 5 weeks. I've never seen one heal at 5 weeks. Fracture type didn't correlate with outcome and conservative treatment for all. And Saxena responded to fresh navicular fractures are not the same with sclerosis, cystic changes, AVN, Mueller, Weiss. There's a whole variety of things that go with this. And most of the patients who have been operated on have already failed conservative therapy. Most of the patients come and see me, unless it's an NBA guy who the trainers pick up on it, they've already failed. So here's a Division I cross-country runner. He wants to go non-weight bearing 6 weeks. This is my experience. It doesn't change. You shock wave it, you bone stimulate, you do everything you can. It doesn't really change. It's certainly not 6 weeks. So if you take an X-ray, yeah, it'll be healed because you don't see anything on the X-ray. But if you CAT scan these people, it doesn't heal. So for type 1, we almost always I put a screw across the type 1. If it's there, if you've got a line, it's your decisions is percutaneous versus open. If you're a type 2 or 3, you get open operation with bone graft. You return to play when the CAT scan documents healing, and you CAT scan them in 10 weeks. So here's a girl who's going to the Olympics as a triathlete. She rolled into the office with this, and Torb would say, no, this can be treated non-operatively. No one would treat this non-operatively. She's 19 years old. She actually made the Olympic team as a triathlete. I use an intraoperative CT scan. So this is JOMO. And JOMO is mostly designed because my X-rays would come back, I do a CAT scan. I'm like, I put that screw not even 90 degrees to the I did this, right? It's probably not the best. It healed, but it's really hard. The bone is round. It's really hard to know where you're putting your screws. So I'll take the patient. I will put wires across the navicular. I'll bring in this little Zyme imaging. I'll take an image. I'll say, okay, I'm going the right way. Now, a lot of my X-rays I've seen by other people, so that's one thing. But also just for yourself, when you're looking at your results back in the office, you want to think you've done the best job. It takes maybe 15 minutes, but it's really hard to get them perpendicular to the fracture site. This is what we see a lot. It's a hard enough fracture to get to heal with perfect surgical technique. So I aspirate. I aspirate from that crest and all these stress fractures, and I use the Jamshidi. I just take the bone graft there. You can get a ton of bone graft with the same, and I do almost under local. I'll give them local. I'll put the needle. I'll do BMAC. I'll put the needle back in 5 or 6 times. Get 5 or 6 sleeves of bone graft. My life is these stress fractures. They're little tiny lines. You get 5 or 6 sleeves of iliac crest bone graft. It works well. So is it healed? You need fortitude when you take care of these people. What percentage? If you look at Ken Hunt and Bob Anderson's healing defined as 50%. What other thing in your life do you say if it's 50% healed, it's healed? Right? There's a good study out of the orthopedic trauma literature about whether a fracture is healed, about whether you can get agreement. Like some guys would say clinically, if you're walking, it doesn't hurt, that's good. Their inter-observer agreement was so low whether something's healed. But when you look at this, it is rare to get 100% healed.
Same with scaphoids in the wrist.
It's the same
thing.
Same thing.
Any healing is healing.
Yeah, so here's a guy, 28 years old. He's got a type 3, knows the bad when he lands from a jump. 6 weeks, 3 months, 5 months, that's healed. That's as healed as I can get, I think. 8 months, rolls his ankle, they take an x-ray, now it's back. And this is repeated often. This is basically Yao Ming.
And did you take that spur down on the neck of the talus? Look like you did.
Yeah,
Because I think that's another risk factor.
yeah. Here's another one, well-known basketball player. This is when he was just drafted, comes out of the draft, he's got this fracture, gets fixed. This is his, I don't do this one, but this is where he is. At 5 months. Kind of disappears because he does it right at the beginning of the draft. This is the spring, and then he comes in with that. So revision, BMAC, fill-in screws, little vascularized bone graft. I'll get to that in a second. Forteo, bone stimulator. We use Forteo often in the stress fractures. We've had the NIH actually look at this. Forteo has a black box warning, can cause cancer. That warning's gone away. And for the MDA, we had the people for the NIH coming up selection. They think it's relatively safe for the young males. Very little data on females with Forteo, but we use Forteo for these stress fractures. I mean, it's so common in the NBA, they'll say, should we put them on Forteo? So Jim Nunley taught me how to do this, the vascularized pedicle graft. It's really, you go to the cuneiform. I usually use a hand surgeon. I'm very lucky I have a good hand surgeon who we have a lot of good hand surgeon. She'll use the Doppler. She'll find me a piece of cuneiform with a vascular leash. And I've gotten out a lot of just chronic non-unions by docking this piece of vascular thing. It is crazy how you don't see, like, because you CAT scan everyone afterwards, you can't even see where you took the bone from the cuneiform. You know, it's hard to actually see where you took this. And the incision is not much bigger. So some of the guys in England are now doing this primarily because they have such lousy results with the particular, and they're actually doing it themselves. I almost feel it's one of the few things I feel like you could do myself. I still like have her do it. She's such a good surgeon. So Jones fracture, again, gets a lot of press. These are very common injuries. And we always worry about the zones 2 or 3. The shaft ones out here, this is the dancer's fracture. This is I tell people in the office, they come out with the dancer's fracture. I said, I'm not the expert on many things, but this is my wheelhouse. That will heal. It's healed. I've got probably 150 dancers who've had a fracture, this oblique fracture way at the shaft, and they all heal, and they all went back to dance. So we published something in 96 with the first 40 patients. We just go to boot, go to shoot, do whatever you want, that'll heal. Tuberosity is a little bit interesting now. We probably fix more tuberosity fractures because of concerns about fifth metatarsal cuboid impingement than we did in the past. But it's the zone 2 or 3 that are the big ones that are worrisome because of the low blood supply. So, you know, the cavus foot, we don't see it in the African-American athlete. This is a guy who's got 4th and 5th. He's recurrent on both sides. He is an African-American athlete, well-known basketball players. But, you know, we think in the NBA, this is a packaging problem with it. You know, these guys are often bigger. They almost always have an adducted foot, and they have a prominence on the 5th metatarsal. It's like, you know, this is all different players. They have this big foot there. And so they're all little metatarsus adductus. I mean, Brooke Lopez is a guy who kept refracturing. Him and his brother both had 5th metatarsal fractures. They're 7 foot tall twins. The woman had 2 11-pound babies. So there couldn't be much room in there. They're both they walk like this, right? 3 of the 4 brothers broken in 4. I fixed 3 of the 4 brothers. Others, you know, so it's genetics. That's a big family. So one of the guys from the Ortho, the tech walks through and he would go like, hey, that's none of those feet with the bump on the bottom. I mean, just spontaneously saw the feet. We have enough reps on this. So operative treatment, percutaneous solid screw is the treatment of choice. Unit rates are higher, the refracture rates are lower, but the debate, type and size of screw in your post-op regimen. So this, we have a lot of cuboid impingement, right? So this is a real thing. Cuboid impingement after 5th metatarsal. That's one of the reasons people take out the screw because it hurts. But if you MRI it, you'll see the cuboid lights up. So it's hard to get this, and some of these feet, to get the screw down there. There's just not that much room. So you want to get a screw that is just past the fracture site. The biggest screw you can get is past the fracture site. So this is a bad one because you're going to try and straighten a curved bone. And the 4-5 angle is very big for the recurrence. So if your 4-5 IM angle is very big, you're more likely to have a refraction. So if you put a straight screw in and you have a crack here, you're actually going to make it worse. You can make it worse during the operation if you ream too far, you push too far in. So we use a short screw, largest diameter. This is I'm a size 12, so this is like I'm like stride right here compared to these guys' shoes. So this is my return to play, my NBA experience. I had a 30% refracture rate. This is good jump. This is like, I mean, I had 2 guys refracture within 6 weeks of each other on the nets with me. I just wanted to hide the whole time in the corner. And they both healed. They both had CAT scans at 10 weeks. And so that was caused me to start bone grafting them all. So now I do the aspiration. I take my bone graft. This is a NFL guy. You can get a lot of bone graft from the pelvis. And I'm just thinking, I'm making a boat. And what I'm really trying to do is rebar. I'm trying to increase it because that's where it recurs. And it's such a slow healer. So I do that pretty much now. Again, I put the vitamin D up there because the only people I see who are not vitamin D deficient are the people who've been treated for vitamin D deficiency. There's studies in the NFL, it's 80% vitamin D deficiency. You know, if you have darker skin, you absorb more, you don't absorb as much light. No one drinks milk, vitamin D fortified milk. None of these guys, no one wants to drink milk, so everyone's vitamin D deficient. So we treat them with 50,000. I stopped even getting vitamin Ds on people. I just give them 50,000, 1 pill a week for 4 weeks. And some of the guys we go to 100,000. We've never made anyone toxic. And we were trying to get a fracture to heal. I think you want to try to get your vitamin D at like 50. Vitamin D, all the vitamin D data is on white women in their 60s. So it's not, it has nothing to do with the young athlete, especially the African-American athlete. So here's a guy, 4th operation. He healed. At the end of the year, he'd refracture. They say, take an X-ray, take an X-ray. You'd have a line or the screw would be bent. 4 years in a row, off season, I did it. Finally, I just said, I'm going to make this as thick as possible. So I put some infuse in there, gave him this here, and that was 2017. Now he's still playing, but this is how he started. So even my technique from 2011 says shorter screw, just past the fracture height, and now he has this big area of bone there. So I'm finally got this to heal. I'm a hero. Everything's great. Next one comes in is a 6'11" power forward. He has surgery. It heals really quickly. Here's a screw. I don't do the surgery. Look at this cuboid here. We'll see this cuboid in a second. He goes back and plays. He has all this pain. He just keeps grabbing his foot. He cannot play. His cuboid impingement. The screw looks like it's in pretty good position, but that cuboid lights up. And his pain is not over his fractures, over his cuboid. So this is 2014. The only headless screws available are AccuTrack. So he has a revision. And it's a small screw. That's the biggest AccuTrack screw when you have a size 20 foot. And he refractures at 4 weeks. So then I see him. This is what the feet look like. These are the bumps under the 5th metatarsal. So I do infuse. Again, I know I did the infuse on the last guy. I was a hero on that. Well, infuse has this tendency to reabsorb. That's pretty variable. So at 6 weeks, they send me this X-ray, and I'm like, oh my God. They're going, we're at a conference called the GM of the team and the owner. They're going like, there's a hole in the side of his foot on his X-ray. I said, no, it'll fill it. And I'm going to go back and like, I'm looking for some Ambien to sleep for a couple of weeks. I can, but he does fill in, and he fills in now, and it's 7 years later, and he's got a big lump. I mean, the bump from this is nothing compared to his natural bump. So the problem, I think, infuse makes, it's really nice. It makes a lot of bone, but you can't predict. You get an osteoclastic resorption before you get the osteoblast. And so you have to have a strong disposition to throw that in someone's foot. So I got lucky there. Now we have these headless screws. This is a very thick headless screw that's made by Extremity Medical. And now the Right Medical ones have a chamfer for the cuboid impingement. So because of my talking about, someone's gone, industry has gone and made some different things. Not me, but take to it. There's probably a better way of fixing it. This is the plantar plate varnish, going back to the same guy, Keith, who was in Houston, reported the IM rod. He's done it in some athletes, a very famous athlete who just came back from the playoffs last year, who's a big guy. You probably know who he is. He got plated. So he's the most high profile guy who's had a plate of his 5th metatarsal. My concern about the plating is the screws will break between the plate and screw junction. Then I have 4 screws going to the 5th metatarsal, and my only bailout is another plate. And it's going to be big, a revision plate. I've been able to get out of everything by revising it with bone graft and another screw. So the plating is biomechanically stronger, but it is, and so we'll see how this player does. It's a big player. So high ankle sprains. So we're going to switch down to high ankle sprains. This is misnomer. High ankle sprains, syndesmosis injuries. You know, if I just eliminate everything except here, focus on the deltoid. The deltoid is the key to treating these high ankle sprains. If you don't have a deltoid injury, it's a whole different animal. So these are guys who I've seen. It's almost always someone they call it a rolled up on. So here's one of my guys from the G League about 3 months ago. He's going for a rebound. You can just see it. And it's actually, we have a lot of them in the NBA now. People are diving for the ball. So again, we know the interosseous ligaments, the anterior posterior, and the interosseous ligaments. Everyone focuses on that. But the deltoid is the key to this. Because if your deltoid is intact, you're probably pretty stable. And if you have a completely intact deltoid, then you're probably a non-operative treatment. Every Monday morning, I'll get 2 or 3 players from the Giants. We just have appointments scheduled because the linemen are here. They're holding their block, and there's all this stuff going on at their ankles, and someone gets rolled up. I'm sure you see the same thing. Someone gets rolled up at it every week, and they're defenseless. Their ankle is just exposed, and someone's falling on them. So the classification and what you're looking for is clearly if it's completely disrupted and it's diastasis, then you're going to get surgery. But your real concern as a grade 2 is trying to determine whether something's stable or unstable. And this is really hard. We have all these tests. We have the external rotation test, the squeeze test, medial tenderness. We have MRIs. So the clinical diagnosis, my favorite thing is to push posterior on the fibula. If they have a lot of pain when I push on their fibula posterior, I'm pretty sure they have an unstable injury. So x-rays for these players are almost always normal. You never see this unless there's a fracture. When you stress them, everyone tries to stress that way, but the better stress is to push them posterior. The fibula goes posterior 11 millimeters, it rotates maybe 9. It's really hard to do this, either in the clinic or in the OR, because your hands are in the way. I mean, you can do it in the lab, and you can see the fibula. This is a section from Mark Dracos' study, where the fibula will go posterior, right? We know that, but it's in practicality, if your hands are pushing the fibula, you're going to see your hands. It's really hard to see if the fibula is really going. So high ankle sprain, MRI will show the injuries, but they don't predict stability. So there's AITFL, PITFL, and we look for the deltoid, right? The deltoid, if the deltoid's gone and you have a ligament to the outside, this is, if you read one article, read this from Jim Calder and soccer players. If you have instability is 9.5 times as likely with a positive squeeze test, 11 times with the deltoid injury. And that's been my experience. If you have a deltoid injury, you're most likely going to be stable. If you have an injury to the ATFL, it indicates a different injury. Now, this is trying to go backwards. Most of these guys have a little bit of an ATFL injury at some point in their life. And fortunately, most of these guys, you have a video of looking at it. But if you have a deltoid injury, you're most likely been stable. So this is a player, this is arthroscopy. This is how far the posterior fibula will go at the time for these unstable injuries. So arthroscopy is a great technique to determine stability or instability, but you're doing an operation to determine whether you need an operation. So that's kind of the hard part about the arthroscopy. So we've looked really hard at this, trying to figure out a way to determine whether these people are unstable or not. And we've done this weight-bearing CT and doing these stress views. So I had my son and all his friends came in, and then we did stress views. I paid them all $25. And I had 30, 25 to 30-year-old people come in, and anyone came walk by, hey, come on, do a stress CT on it. So we did the study, we published it. So basically, this is what it looks like. I mean, bilateral strain stress. And if you internally rotate, so I have the people stand and then internally rotate their body with their foot fixed, it doesn't change on either side. No, it doesn't change. So there's a lot of data now about this. We looked at the normals here. And we're about to publish now, we just published this, and now we're about to publish our results of the ones that are loose. So we're looking at a volume measurement now. Now we have a way to do the volume measurement. This is the twisting using the curve beam. And you'll see patients will come in, if there's any difference, it's unstable. So you'll see patients will come like this. Sometimes they can't hold it because they just hurt their ankle, but you'll see the fibula rotate. And that's really one of the best things about the weight bearing CT for using for the syndesmosis. So the sports guys will just, I guess syndesmosis can they don't care if I'm there because our techs will do it. They'll just send them over and I'll show up and go, so they sent 2 guys over for stress use of the syndesmosis. And so this is a really important thing for us that really helps us determine whether they're stable or unstable. Again, the deltoid repair controversies, I've been fixing the deltoid since 1993. I went from pariah to pioneer. And it's mostly because the early studies were really poorly done. Donnelly study shows it really helps stabilize the syndesmosis. You get the bare spot. You guys showed a nice study that you'll get the superficial deltoid, you get a bare spot on the medium malleolus. I mean, if they have a significant injury, they're going to be swollen. It's rare for them not to know before you do it whether you have the bare spot. So Bob showed this good results for repairing and for fractures. There's a study coming out that showed it works well for non-fracture high ankle sprain as well. So this is my standard. This is tight ropes with the medial deltoid repair. There's a lot of discussion about whether you should do tight ropes or whether you should anatomically repair the AITFL. I think anatomically repair the AITFL makes a lot of sense. And most of the studies will show now you just have to repair the anterior portion of it. The studies on the tight ropes will show it doesn't really hold much for a lot of translation. And my point of that is I'm actually okay. I want this to be stable, but I then want to move a little bit. My concern about the primary fixation will be too stiff right here. So while the tight ropes are imperfect, I think at this point, they're probably still my treatment of choice for most of these injuries. The tight ropes and the deltoid combination, I have not put a syndesmotic screw in probably 15 years in anybody. So we'll switch now. So the third thing that I see too many of it is Achilles tendon rupture. The goal of treatment for your Achilles tendon is no matter what, you want to restore the muscle tendon integrity, and it's your tension. So it's all about the tension. Whether you treat them non-operatively, you have to restore this tension and also try to avoid complications. So we know that the resting angle relates to tendon length and function. So if you are loose at 3 months, it's not going to be a good result of the year. So when patients come in, they look like this on the left. One leg is down, one leg, and so there's too much tension in the system. And this is the only thing I have a goniometer for. Probably people don't even use these things anymore, but I'm just trying to see what their tension is. Because even operative repair stretch out. This is a great article. They fix it, open procedure, good solid repair, put them in a cast. Half the people had more weight, half the people didn't bear weight. Everybody stretches out. So you just have to assume whatever you do in the operating room is going to stretch out, or whatever you do in the clinic, if you treat them not operatively, where you start, it's going to stretch out. And the stretch out is biggest between 2 and 6 weeks. When we're trying to do this early mobilization and early walking, but it'll still stretch out up to 3 months. So decision one, when you see a patient with Achilles tendon, do you operate or not operate? This is a real decision. Landmark trial in Willetts in Canada, accelerated functional rehab, Canadians. If you got it within 3 days, they put you in a boot with your foot in plantar flexion, let's start bearing weight. Acceptably clinically similar results, except for significant difference in plantar flexion at high speed torque, which is important for an athlete. Unfortunately, that study has been tried to replicate by a couple different people who found this weakness in end range plantar flexion after Achilles. And a couple more studies out of Scandinavia really showed that the surgical group had better physical function, the peak torque was higher, and higher ankle strength throughout the range of motion. So this is the way I tell people. This is my son who played college soccer. If he loses 10 or 15% of his jump, he may miss that header. This is me doing a layup. If I lose 10 or 15% of my jump, I may notice it, but no one else will notice it. I have a 12-inch vertical leap. If I go to 10.5 inches, it's still not good. So if you take a look at the player and you get a patient, just be honest with them, like, this is what you can do non-operative. If you really think, and because I practice in Europe, everyone is an elite athlete, no matter what. They're all like, they used to play this, and they used to be so good. So you have to be honest with them. You have to trade off the potential complication of surgical complication versus the end result you're getting. You're getting better peak torque. You're able to do a little bit better counter jump movement, high-speed plantar flexion torque. Hopping. How much do I hop, really? I mean, I play tennis. I run around. I'm pretty fast, but I don't think it would really matter if I had mine fixed or not fixed. Weekend athlete, I don't know if I'd fix it. I used to always think I would fix mine. Now I'm thinking if I ruptured my Achilles, I'm probably going to put myself in a boot and just deal with it. So now your first decision is operate or not operate. Second decision is how you operate, open versus mini. So the theory about these mini incisions are started out with a PARS technique is it would be less risky, less complications. And if you look at this is what you do in the operative. I prep both legs. Every time I prep both legs, because I want to see how much inversion and plantar flexion. You have to look it from the end. You can't look from the side. And I do this in the office too when they come back. So the mini incision is supposed to be less risky, less complication rate. Does it really have lower complication rate? There's some randomized control studies, and they showed early on that did, maybe had less wound infections and higher satisfaction. But if you look at other studies, open versus non-open, this is Anderson's study, who's a big proponent for professional athletes of doing the PARS technique. No difference in wound. The certain nerve injuries were actually higher in the open procedure, but they're about the same. So they said the open versus percutaneous, the results were the same. The results were a little bit better with the PARS technique in terms of complication. But this is a study, we'll get to this in a second. There's 270 consecutive Achilles. That's a lot of Achilles. And the DVT rate was 0. We'll come back to that in a second. So if you look at other studies, this is out of Mass General, 615 patients, retrospective MS for 3 different centers, no difference in complication rates, except for the trauma surgeons had a higher wound and re-rupture rate. Well, let me tell you, if I had to do a subtroche and they looked at the foot and ankle guys doing subtroche fractures, I imagine the complication rates would look right. I am sure none of those trauma surgeons wanted to do that operation, So, I mean, this is how they just separate out by service, actually. But small incision feels better, complication rates the same, but the strength isn't very good. We know that the ultimate, it's shown to stretch out. You maybe get one locking suture on either side. So my whole concern is stretch out, even with the open procedures. I just don't trust this. I just can't trust it. So even though I've done it, so I did it for 18 months. I said, I'm buying into the PARS, I'm going to do it. I had about 30% intraoperative failure. I would do it and I would pull, and I said, this just doesn't feel good. So then I would open it up. I had guys like this. Here's a pro athlete, European player. The MRI read as a gap. It looked like there's just a gap right here, but he had this kind of sleeve avulsion. Here's an NBA guy. This is his Achilles. This is this part of Achilles in the middle. This is his other Achilles. I would miss that with the PARS. So I now there's a variety of different techniques. Whatever you do, I think you don't want the sutures. The sutures can be here, but you don't want this big suture mass on both sides. So the PARS technique keeps the sutures on both sides. And what I was finding was people would have this big area of induration and swelling. And my aha moment when I stopped doing the PARS, when I had a 27-year-old dentist who had this for 6 months afterwards, nothing's infected, and he had open re-rupture just jogging on the beach. And so one of the things that I'll touch on later is I just start calling people when I see that. Like, has anyone seen it? Oh, and other people have seen it too. These open re-ruptures. And you get this indurated swelling because you're locking these big pieces of fiber wire on both sides of the. So here's a defense end, acute Achilles rupture in 3 months. He's walking around, felt a pull, ultrasound negative. I have this story probably 4 times in the past year. And this the PARS technique, and I think it just slowly stretches out. So he's got this kind of mass back here that's swollen. his tension's way off and he needs a revision. Now he's 5 months post-op. That's not good. So you get in there and you find this big kind of hole in the middle of it. My go-to for the revision for the professional athletes is the hamstring autograft. I'll take your hamstring all the time. We have probably now, we did a study, we're about to publish about the strength of one hamstring. And the sports guys love to tell us that one hamstring, we have about 99% strength of the knee, taking one hamstring. I mean, the other studies are doing the ACL, I think you guys can focus on this. The ACL taking the hamstrings, pretty good knee strength, but you also had a knee operation at the same time. But this is just what your knee does if some foot and ankle guy goes and takes your hamstring. I think it's better than FHL. I think if you're a power athlete, you need your FHL to really push off. So my technique, stay medial, open, locked banal. I use a number 2 ortho guard. I don't use a fiber wire. I use a vicryl at the end. I grab the suture with a vicryl because if I use an Alice clamp, I usually tear it. I set the tension of the vicryl, then I kind of adjust it a little, the main repair, and I try and make it tighter. And then so far my acute wound infection rate is 1 in 27 years, staying medial. It's my friend, he's a psychiatrist who fell in my office as he walked in for his post-op visit. I get to see him all day long. Usually we do like a flap, it was just a disaster. So here's the medial incision, this is Kobe. You have a big lateral incision, but they did make sneakers afterwards. This is the Kobe, whatever, 9s, which have the thing for the Achilles. So that's a pretty good sneaker. If you're having your Achilles, have your patient get a pair of those. If you stay medially, it can be a pretty small incision by the end of your time you're done. Decision 3 is your post-op management, and this is all over the place. We know you want early mobilization, you want early weight bearing, but if you look at, this is just a slide of a group in New Jersey, and like everyone's different. It's all over the place. And I think what you can take home from this is when we had our player do it, we had people opine from all over the world. They basically had when he was having a glass of water, for the first 3 months. But really, if you look at it, even the Kennedy Fowler functional rehab, if you look at it, they're saying, protected weight bearing, active plantar flexion, dorsiflexion to neutral stretch between 2 and 6 weeks. It's going to stretch out then. So mine is, if you look at my protocol, I just tell people no passive push -15. I just keep telling them that you're going to be tight. You should be tight until you're 6 weeks. You work in plantar flexion. You get a splint for a week. We do blood flow restriction in a week. Blood flow restriction is a way to sort of trick the calf muscle to staying strong. So we have the Owen system where we get their occlusion pressure, and they just buy this blood pressure cuff for $100 and they start doing blood flow restriction right away. So blood flow restriction, they do that, and we keep them by 6 weeks. They're just approaching neutral, but they are working like crazy in plantar flexion because I'm afraid of everyone stretching out. So we stretch out, work the JOMO, goals approaching neutral at 8 weeks. When you get to 10 weeks, I think you can push. No one is ever too tight from a primary Achilles repair. So when you're setting the tension on, have you anyone ever made anyone too tight? You can make them too tight with an FHL because it's sort of out of phase. You lock it in the heel with a suture anchor, but no one has really been ever too tight with the Achilles tendon. And there's no great solution for a slightly stretched out Achilles tendon. There's, going and shortening it. The calf muscle's been not loaded for a long time, doing a tendon transfer. It's okay surgery at best. It's not, I'm back doing everything I want to do. Because the tension, the rupture square 3 months can predict your ability in a year. That is the big trick with this. And then the bigger decision, even bigger decision, is to anticoagulate. From Anderson's study, you don't have to anticoagulate anybody. It's 270 patients, no DVTs. This is a Kaiser study. They did 1172 patients with Achilles tendon. The risk was 0.43%. Why would you ever anticoagulate it? Well, if you look at it, everyone has a clot, or a good percentage of it. If the studies of Scandinavia, if you ultrasound people, non-operative and operative treatment of there, you're getting clots in a third of the patients. We almost, the nice thing, when you have 12 people or 12 people doing foot and ankle at the same institution, you have a conference, a complications conference. So a DVT after Achilles, most of our guys now are on Ortho for 2 weeks. We just assume they're going to have a clot. There's something unique about the Achilles tendon. When it ruptures, the calf muscle goes, there's stasis that ends up with a clot. So if you look at us, if you look at all the Scandinavian studies of prospective studies with ultrasound, there's clots all over the place. Now, the question is whether you have to treat those. But in 2022, do you treat a calf muscle clot with an oral agent? Or do you just say, well, it's not going to go anywhere? I've had 2 guys with real PEs. We've had people with PEs on Ortho. So there's something about, so you have to really have the discussion. So when I see a patient with Achilles, I say, all right, operate. This is my 3 to 4 decisions. Am I going to operate on you? No. Based on what your life is like and what your expectations are. And I do open versus mini. And I almost do all mine open because my mini technique was not very good. Maybe I wasn't good at it, but I had some really bad results with the mini technique. How fast am I going to move you? I'm not going to let you go too fast. I'm going to let you plantar flexion, move you really fast and weight bear. Like if you watch Durant on that video at 8 weeks, he was doing a slant board down. He was not going past neutral. That was really, down at 30 up to 15. So you can work people in plantar flexion to keep their calf muscle going. You do not have to have moves that fast, and they'll still have a good result. And then finally, am I going to anticoagulate you? And if you have those discussions, you'll never go wrong. And even if you have a discussion about anticoagulation and you don't anticoagulate, just put them on aspirin, then you're protected. So assume all Achilles have a DVT. We pre-op evaluate anybody who's flown in. If you've flown and you're on vacation and you've ruptured your Achilles, you get an ultrasound. You do not go to the order for you get an ultrasound. And I've operated probably 10 people with an acute clot who've had an Achilles. We just don't use a tourniquet. It doesn't bleed much, as you know. You make the incision, use a mini. This is probably a good indication, even for Parr's technique, but a mini incision, you fix it, and then you anticoagulate them afterwards. So how did you beat the worst injury in basketball? Those are the 4 things. We got him going. We moved him early. Got his tension right. We stayed medial. We didn't get an infection. We did blood flow restriction. We had a class 4 laser as an apartment. We did, when you have a guy moving in with you for 6 months, it's not realistic, And also, if you read the article, he didn't come back for 18 months. Your results at a year are not as good as your results at 2 years. So it takes a while to come back. The athletes, the first year back, their performance is down. By the second year, it's right on the same level. So, I mean, it's one, you have a person who's like crazy 1.1% or whatever. And 2, if we just are smart enough about it, we set the tension right, don't move them too early, stay medial, make sure it doesn't get a clot, and work them in plantar flexion, I think you can have a good result. So the JOMO thing is mostly my failures. Everything in that book is like, don't do that because I've done it, it hasn't worked, So the thing I tell the residents is don't hide from your failures. When something goes wrong, just go and ask people. For me, for the 5th metatarsal, when I had my second refracture, I called up all the sports foot and ankle guys in the country. There's nothing written about refractures in 5th metatarsal. I said, do you guys have this? Oh, we get them all the time. I'm like, well, we're doing something wrong. These people are refracturing and no one's talking about it. And I'm seeing here, so we need to start talking about refractures of the 5th metatarsal. Everyone's got refractures and no one's talking about it. So that's how I became like patients would come to see me for the 5th metatarsal because it's like, this is not working. This is what we're doing. And this is how I started bone grafting. It's mostly because of my own failures. So when you see a failure, go ask someone. That's what's nice to be here. What's really nice about the way you built this now is you're all together. Like the residents are sitting, I love the residents all with your cubbies there. You'll learn so much from each other. There's just a certain point you learn books, but just walking around and talking to other people, you'll learn so much. So I'm on an email, a text list with these guys all the time. None of these guys dropped out a little bit. Tom Clanton's retired, but he still emails all the time. But it's twice a week. And there's probably 200 years of sports foot and ankle experience there. And we're still asking people questions. We're still like, hey, ever seen this? We just had this kid with an unstable subtalar joint. He's dislocated it 3 times. No one's even heard of it. So we're going around and we keep asking. That's how you learn. That's what's nice. So get on an email list with the people you're fellows with or anybody else and just say, hey, ask. Just because someone's already probably done it. And they can give you their JOMO, no, don't do that, I've made that mistake, and ask people what to do. I want to thank you guys for asking me here today, Dr. Park, the chapter for hosting me at dinner. I think the fact that you've consolidated this is a game changer. I really do. It reminds me of when we started, we were all in one group, and there's 30 of us, and we'd walk around, we learn from each other. There's a certain level that you get to make. When I look at the spine and the sports and things, someone has a spine problem, they could go show the foot and ankle guy. It really is going to be a game changer. We cannot do that now. We're so fragmented now. We're so big. We have probably 5 or 6 different buildings around the hospital people are in. We're all in our own little pod. It's not great care for the patients, and it's not a great way for your colleagues. I mean, I only talk to my foot and ankle colleagues. I operate with them. We have the hand and foot. Occasionally I'll talk to a hand person. I never see the rest of them. I see the sports guys because of the team involvement, but otherwise it's way better to be on one campus in one group, especially for teaching. I mean, for just about recruiting residents that come here, they see this. I mean, it really is, it's going to be a game changer for you guys. That's the crew. Thank you. Another day away from them. And most of the time, they don't like me that much anymore because I'm now old. But they're little, they like me a lot. I got three adopted kids and 3 biological kids. I'm very lucky. They're all healthy. Thanks.
Questions? That's fantastic.
Thank you.
Absolutely awesome.
But Martin, when you talk about the 5th metatarsal refracture rate, we've had many conversations, the 3 of us, about the different weight-bearing protocols after fixing it. And many of my colleagues who I respect will say, and we had a sports conference, and some of the greatest leaders of our field were like, oh, just let them walk right at 2 weeks or 1 week.
Yeah.
And I let them move, but I don't let them weight bear for 6 weeks. I don't know. There's probably somewhere in between that's right.
Yeah, it depends on, is this an acute fracture? Like, so the 5th metatarsal, you can get like an ankle sprain in an acute Jones fracture, or do you have sclerosis that's been going on for months and months and months? Those are going to heal slower, right? So I usually, first of all, worried about my wounds. So wound for 10 days or something, you're just in a splint. And then you're going to boot. I'll let you touch on weight bearing. I'm big on, I'm big on the disuse osteopenia of non-weight bearing, about the effect on the bone. And some of it's because of that weight bearing CT scan. The weight bearing CT scan kind of gives the architecture of the bone much better. And you get some people that the bones look terrible after a few weeks of non-weight bearing. In fact, that company is now joining with another company, and they're going to be able to do bone density just in 640 seconds with weight. And so, because the data you get from those weight bearing CTs are going to look at the bones and say, okay, your bone's osteopenic. But so I'll have the patients, everybody, you got to at least stand a couple times a day. You just stand on it and you are just weight bearing. So at 2 weeks, they're touchdown weight bearing. So they're like this at 2 weeks. A little bit of weight bearing. I don't think it really does anything. That little bit of limited weight bearing. At 4 weeks, if everything was okay, they can walk around their apartment with the boot, but they're outside, they're on crutches until 6 weeks. Then we take an X-ray, and then you follow the data. It's a CAT scan or a plain X-ray, just looking at its healing, looking at its not healing. We have a very famous 5th metatarsal fracture that's going in the NBA that hasn't played all year, and so he just, everyone knows that Zion Williamson, he had a screw, it didn't really heal. It's all this, stuff going back and forth. And like 6 or 7 months, they did a bone marrow aspirate into it. Well, I'll do a bone marrow aspirate in 7 weeks. If this thing does not look, it's blood supply. If it's not looking the way you normally expect it to fill in, thinking this is something else. So taking a bone marrow aspirate at 7 weeks, I mean, I've done probably 10 bone marrow aspirates on professional athletes in my office. I just get some local, some of the guys video it. It's weirdly is not painful. I know it seems that way, but you take that, it's scary. You're taking a hammer and you're doing that. But the bone marrow aspirate is really, I think it helps. Joe Lane showed it does form bone. It's the concentrated bone marrow does form bone. So I think the weight bearing, a little bit of weight bearing is okay. I don't think there's any danger of sort of keeping them off for 6 weeks. I mean, just the goals that they end up healing.
Right.
And no one remembers in 6 weeks. I just worry about the disuse osteopenia. And my concern is look at those CT scans and getting guys coming back with like some cuneiform stress fracture because of an off it. And now I have to deal with something else. That's my big concern about the weight bearing.
How do you navigate, especially when you're early in your career, the poor outcomes, the less than optimal outcomes when you have a high level athlete or something like that who, you do what you think is a perfect surgery and then 6 months later, they're not doing as well as you'd like them to do?
Oh yeah, so I'm on a bad streak. And I had my first like infection in a professional athlete at a revision, crazy, high profile, $100 million athlete. But this is when I was early in my career, I had those 2 fifth metatarsals. And all I think the best thing to do is be as honest as you can be, is don't hide. Just say, look, we did this the right way. You broke. Let's get another opinion, ask someone else, ask for help. I just ask for help all the time. I send them around, I said, I've gotten 4 opinions on your foot. We all agree this is this way. We all agree this is done the right way, but it still goes on now. We still have complications and people go, they get on the plane, they go somewhere else. They fly around. So our famous, and Joe, I talked to Joe Harris. He said I could talk about his ankle. He's unstable, best guy in the world. Best person you want on your team, unstable ankles for years, tapes at halftime. Nobody in the NBA runs into halftime and retapes their ankle. He retapes, he's been doing it for years. He sprains his ankle. He's got impingement loose pieces. He's had them since 2016. They're loose, he's sore. Take him to the operating room, take his pieces out at 2 weeks. He feels like he can't go back, take the pieces out. His tailor tilt's probably 50 degrees in the operating room. But it's November 30th. You do a lateral ligament reconstruction, he may be done for the year. At that point, he sprained his ankle like everybody else in the NBA. There's an ankle sprain every night in the NBA. Someone comes down someone's foot, take the pieces out, he goes back, he's on the court 7 days shooting. It's like, this is great. His goal is to play Christmas, the Christmas game, the big Christmas game he wants to play. He just never can get over the instability. It just, one way he'd go around a screen, the other way he couldn't go. If he just had to go left, he'd be fine. But he could not come around this way. If he went that way, he felt like his ankle just was too loose and it would pinch and it would slide. So this, for me, that's a failure. I mean, it's my team. I made the decision just to do the scope and not to do the ligament reconstruction. I see him every day. We braced him. I mean, it's like, hundreds of hours trying to get him going. But I'm like, you just have to, Joe, this is what we decided. And he's all good with it. I mean, when someone else did the ligament reconstruction, which was fine too. Like, you just like whatever you want. We're just trying to get you back. But as long as your indications are the right way, as long as you're honest with them, like this is like the reason I learned so much about the fifth metatarsal is I tell Brooke Lopez all the time. He says I can use his name. That he taught me more about the fifth metatarsal than anybody in my life. And he stayed with me. He goes, no, I got you, doc. I'm good. Broke his foot. Okay. We weren't even going to play him because we were trading. We didn't let him play until 3 months. 3 months. He was healed by CT scan, solidly healed. Lands on another player's foot, refractures. Right? Now he's not getting it fixed again because he's getting traded and stuff like that. He let me BMAC him in the office, right? Every month for 4 months in the off season. Healed completely. Thing was healed by CAT scan. Goes and plays, dislocates his posterior tibial tendon on the other side. Freak accident, inverts his ankle, wants to go back and play, doesn't want to come out. 8 days later, breaks his foot, re-breaks his foot. So that's 2. Redo it. Go back, plays the whole year, comes back after a few months and do both ankles, plays a few games, end of the year, take an x-ray, screws bent. Take the screw out, dorsiflex his first metatarsal, even though he's not really in cavus. But we're thinking there's some varus in the system, do a little dorsiflex and osteotomy, heals, great, plays the whole year, end of the year, as his physical, got a big crack. I mean, how many, but I said, you should go somewhere. No, just keep doing it. Okay. He did make $165 million during that time, and he only missed 4 months. But I did 4 operations on his fifth metatarsal. Yeah. Right. And so that was the infuse and that whole thing. And I thought I had it down there. And, I mean, I don't use infuse much for these fifth metatarsal fractures. I would use it as a revision, but it's hard. It's, you would, especially for the college athletes, because it's all about the future. right? The potential, like if something goes wrong, what am I going to not be able to play? But you just go from the beginning that we did the right thing here. Everyone has mistakes. No one doesn't think, no one doesn't have complications. No one's bad with us in this.
It was easier for someone with your experience versus.
Oh, it's way easier now. Oh, it's way easier now.
Like early in practice.
Oh my
you had
God,
One.
you don't sleep.
Yeah.
You do not, I mean, this is, and if you don't sleep, that means you're a good doctor.
Yeah.
If you meet guys who like can brush it off, go to bed at night and not think about it. I mean, I still like when these things happen.
Mhm.
Like the past 6 months, I've had more sleepless nights over 2 players who, for whatever the personality and the complication, and they were both revisions and they're both done exactly the right way. And I wouldn't have changed anything, except maybe some post-op management that was done from afar. So you can always like blame that. But with that, they had complications. I don't know why they got infection. I don't know why it looked like I've done everything else. I mean, wasn't expecting an infection as a complication from it. But it's awful. It's awful. You feel terrible. You feel terrible for the player. But it's part of the nature of what we do. And just be honest, if you got an infection, you got an infection. We have to treat this. This is what we have to do.
It was refreshing to hear that. I know that all of us,
Oh no,
none of us sleep.
we still.
I had a full head of hair in this off.
I did not have gray hair. I used to have that. I look at now like the pictures, like at the Nets game, the photographer goes, I need a picture of you. I'm like, why do you possibly need he has a list. Why do you possibly need a picture of me? Because the only person who cares about that picture is my mother. No one, like, what are you doing with this picture? Every 3 games he's taking. I said, is it like documenting that I'm here or something? It's like my punch card that I'm at the game? He goes, no, I just get a list. I'm like, what do you do with these pictures? Every time he sends me a picture, he'll take it, he'll send it to me. I'm like, oh my God, it's just getting grayer and shorter. It's the players. It's not. It's just because of the stress of what you do. But look, I'm blessed, I'm lucky. But the point of the whole care of the professional athletes, why it sounds great, it's not, I'm the Olympic doctor for Paris in 2024. Right? It's 4 weeks. It's a 4-week commitment. You're not getting paid. You're the only doctor for the men's and women's team, right? So if you have one of the female players with abdominal pain, they're coming to you. There's no medical backup. You can go find another doctor. But so we've argued with the Olympic team. Well, we've always done it that way. I said, I'm foot and ankle. I'm not even like a good orthopedist, like the shoulder and like one of these guys dislocates your shoulder. Do you want me to put it back in? No, like it's like you have a hip thing. I'm foot and ankle, let alone taking care of the women's team. But I'm there, I go to practice with them. I'll go to the games with them. I did it for the preseason thing in Vegas before the last Olympics. I mean, it's a great honor, but do I want to lose a month of my life? I still have people I have to pay in my office. We have a staff of 10. A lot of people get paid. And do I want to do I just want to work for 2 weeks and then go to the Olympics for 2 weeks and go to all the events and have fun? Right? But it's like you be careful what you wish for. When you get to a certain point, you think like, I'm not so sure this is the best thing you're doing.
Great. Regarding deltoid ligament reconstruction, like can you just go through the algorithm? How do you do it? How do you do it? And if you do a deltoid ligament reconstruction, what is the post-operative protocol?
Oh, I move them pretty fast actually. They're 2 weeks there. I think the deltoid lets me move them faster. So I'll make the deltoid and put the anchors in the bare spot. So we were talking about last night. What's the order? I do the scope, do the deltoid, then come back to the fibula to do the fibula. And then I'll move them pretty quick. They're touchdown weight bearing clearly by 2 weeks, and by 4 weeks they're almost fully weight bearing. I think when you have the tight ropes and the deltoid reconstruction, the concern of these big injuries is stiffness. So we try and move them as fast as we can. If there's nothing worse than a beautifully done stiff ankle or any joint. It looks perfect, and they come in, doesn't move. I did my job, so I think moving earlier is better. And I think the deltoid, you just have to know, you tell them it's going to stay swollen for a long time. You're going to be swollen on the inside, you're going to be stiff on the inside, and just because you had a combined injury. Whether it's a surgery or the treatment of the surgery, it stays stiff. That deltoid scar stays thick. Mm-hmm. That and the whole thing just stays kind of brawny and swollen for a long time to do the reconstruction.
One more question about the syndesmotic fixation. If you do an anatomical reconstruction, AITFL, put anchors in, always, think about over tightening this, how tight you should put the anchors in and how tight. It's always the case. We did one couple weeks back, like we felt it was too tight.
Right.
So how do you do an anatomical reconstruction?
That's what keeps me doing the tightropes. Because I'm pretty sure I've never made, but I know there's complicated. Because of what I do, when I get every complication there. So I've seen 20 complications with tightropes, but there's thousands of tightropes done every day. So I think it's a pretty safe thing. The thing I've seen with the anatomic reconstruction is just pain and too tightness. Now, I haven't seen it in like a big time athlete, but I've seen it in people who just had a syndesmotic injury, like a regular person like me, come in and broke my ankle, and they have pain over the AITFL. The problem with the internal brace is, as we're talking about, is it rubbing on the bone as it's going around there? Is it causing this reaction? So what we usually do is we'll look at an MRI. If there's a lot of bone edema, I'd say, look, we put this in for the same reason we put a syndesmotic screw, we can just take it out. Like the ligaments heal, take it out. I have very low threshold after 3 or 4 months. If they're still having pain and they have an anatomic ATFL, take the thing out. The tightropes don't do anything at that point anyhow.
Any more questions? Joe?
The chat, check to the chat.
Yeah, those aren't questions. Those are just comments.
But I think one thing, Winston mentioned is for all of us who are, when we were younger in our careers, having people like you and Bob who I can reach out to and share some like challenging cases. I think that is the thing that has helped me the most, not necessarily lectures or
Absolutely.
journal articles, but people who will say, oh, Joe, don't do that.
Yeah.
Here's a person I tried it on and failed miserably.
Yeah.
That's more.
It's just reassurance for yourself, because when you're by yourself in the operating room, the X-ray goes up, you're like, oh, and then you gotta think like you're the only person that's happened to. It's happened to everybody.
Yeah.
Like I have a guy the other day who's the 5th metatarsal, he's going to go to the NBA. I fixed him, and he's like 6 weeks. I'm like, it's like I wish it was a little more healed. I think he's going to be fine. But now we're in the point where he's got to go to Phoenix and get ready for the combine, and how hard we can push him. And if he doesn't perform well, he'll get slotted out. I mean, if you're an NBA player, we had Adam Silver, we have this doctor's meeting at the NBA thing at the All-Star game. If you're an NBA player and you're a lottery pick, so you're in the top 10 or 12, and you have a good 3 years, and you get extended in your contract, and then you have another good career, your estimate you'll make in your lifetime is $450 million. Now, if you're an NBA player now, the money is just, it's not just generational money, it's multi-generational money. You're setting up your family and your heirs for generations by doing this. So the pressure on this whole thing is just immense. And these guys, these freshmen at Duke, I've seen 3 of them. Those guys, that group, at Novicchio, it's all like, just, they're in high school. You're going to the NBA when you're 15. You're slotted out. They've got you somewhere. They've got you. You're at Mount Herman. You go to different schools. Northridge. They spot you. They know you're going to go there, and then it's all the people around you with different. Your parents. Those Kevin Durant's mom said it was like herding ducks for him when he was in high school and college. She would she'd go around and like shut the doors. Like she would like keep me having everyone be open these doors, shut the doors in front of them. No, you're not doing that, not doing that, not doing that, not doing that. She had to protect him from everybody because everyone wanted a piece of him. And she was like, just this is her job. Her job was just to protect him from everybody else. Now, fortunately, he's like a smart guy and can protect himself. But if you get kids who don't have the savvy and they're just thrust into this limelight with all this stuff, things can go bad pretty quickly.
Great. Anything else? Thank you.
Sure.
Yeah.
Thanks for having me.
Yeah. Oh, sure.